Stroke on one page. Please read a disclaimer before continuing. This is the map that we will follow during this presentation. It contains a thought process on diagnosis, management, and prevention of stroke. So let's get going. Stroke on one page. Once we identify that the patient is having stroke-like symptoms, there are several key questions we need to address right away. Which ones are the symptoms? We can triage beginning with the BFAST scale. Next is to figure out when the patient last known to be at baseline. The question is not when were the symptoms first noted. Then measure the intensity of deficit. The most common tool is the Nih Stroke Scale. This make or support the decisions that we will be making. A parallel question is, are the symptoms of the acute stroke disabling? Also, we will need to figure out the pre-stroke functional status of the patient. For that, we use the modified Rankin scale. This score will also help us make or support the decisions that follow. If we're going to consider the patient for IV alteplase and/or endovascular therapy, we also need to review the contraindications for the procedures. If the patient is still having symptoms, then we will need to get a non-contrasted head CT scan done immediately. The main reason is to document that the symptoms are not due to an acute hemorrhage in the brain. If the last known normal was less than 4.5 hours, then the patient may qualify for IV alteplase. Start checking the vital signs at least every 15 minutes, if not more frequently. To give IV alteplase, the goal systolic blood pressure should be between 120 and 185. Some recent publications suggest that the best blood pressure range for an acute stroke in the first 24 hours seems to be between 140 and 180 millimeters of mercury. If stroke symptoms are disabling, and the patient is within the first 24 hours, then we would be thinking about performing a CT angiogram of the neck and brain. We do the neck to be able to understand the anatomy of what may be endovascular navigation to come. If there is a target for endovascular therapy, then ordering a brain CT perfusion would be the next step, especially if between the 6 and 24-hour window. The patient should not get a test that would not benefit them. If the stroke symptoms have cleared, that is, the patient has 24 hours, the better initial test is the MRI of the brain, and may consider to forego head CT scan.
Following the acute decision-making, the thought process moves forwards identifying the mechanism for the ischemic stroke. There are essentially three basic mechanisms for an acute ischemic stroke. Mainly, the pipes, the pump, or the plasma. The pipes can be divided into small and large arteries, and less commonly the veins. Probably the best test or pipe imaging is the CT angiogram, followed by carotid ultrasound, followed by MRA with contrast, and lastly MRA without contrast. The main area to image is the cervical internal carotid artery, as there is the potential option of carotid endarterectomy, if on the same side of the stroke there is stenosis between 70 and 99%. Outside of the decision-making for endovascular therapy within the first 24 hours, the decision to image intracranially needs to be thoughtfully made. As of 2020, there is very little opportunity for intracranial endovascular procedure for secondary stroke prevention. The management for intracranial arterial stenosis is medical. This may change in the future. From the pump perspective, that is from the heart, the two most common sources of cardioembolism are atrial fibrillation and severe CHF. Less commonly valvular disease, endo may be the culprits. Stroke from cardioembolism is frequently prevented with anticoagulation. Sources of a stroke from the plasma are a lot less common, and they include hypercoagulable state, hyperviscosity states, and others. Most hypercoagulable states are venous, which would necessarily invoke the presence of a right-to-left shunt. A lot less commonly arterial hypercoagulable states are diagnosed. The management of hypercoagulable state may include anticoagulation. If the workup is completed, and no convincing source is identified, then it's important to consider the diagnosis of cryptogenic stroke. One of the important tools in this situation is long rhythm monitoring. This decision may be ready to be made by 24 hours after admission. For secondary stroke prevention, identifying the modifiable risk factors is important. Some of the modifiable stroke risk factors are chronic arterial systemic hypertension, atrial fibrillation, smoking, sedentary lifestyle, sleep apnea, dyslipidemia, diabetes mellitus, illicit drug use, and poorly managed stress. Identifying the risk factors helps to deploy strategies specific, as well as generic, for secondary stroke prevention.
About 80% of the strokes are ischemic, and the remaining 20% are intracranial bleeds. The most location and mechanism for intracranial bleed is the deep intraparenchymal hemorrhage secondary to chronic hypertension. Intraparenchymal hemorrhages are managed by neurology. When the bleeds are outside the brain, that's typically neurosurgical management. In the management of intracranial bleeds, some steps to remember are to place the head of the bed up 30 degrees, as that is a point balance between arterial perfusion and venous drainage to help maintain the intracranial pressure, at the same time as decreasing the pressure head on the ruptured vessel. Aim normal blood volume, as hypovolemia or hypervolemia increase morbidity and mortality. The goal systolic blood pressure in the first 4 hours should probably be between 120 and 160 millimeters of mercury. Antihypertensives such as labetalol and nicardipine, and others, are commonly used. Some important red flags in acute stroke are Glasgow Coma Score 13 or less, Glasgow Coma Score declining by more than 2 points, and ICH score Nih Stroke Score of 10 or greater, and ABCD2 score and TIA of 4 or greater, spontaneous subarachnoid hemorrhage which is likely to be aneurysmal and poses the risk of rebleeding, intraventricular hemorrhage, large subdural hematomas, cerebellar hemorrhages of 3 or more centimeters in diameter, clinical evidence imaging evidence of cerebral herniation, and the presence of coagulopathy. In stroke, either ischemic or hemorrhagic, there is no indication for prophylactic anticonvulsant, corticosteroid used, intracranial stents, or with very few exceptions the use of heparin. Those clinicians taking care of stroke patients in the emergency room or in the hospital must be versed in the following stroke-related scores or scales: the Glasgow Coma Score, the ABCD2 score, ICH score, CHADS-2 score, the Sedan score, the Hunt-Hess classification, and the New York Heart Association classification. It goes without saying that the Nih Stroke Score is the default standard examination for patients with acute stroke symptoms. In this YouTube video, the Nih Stroke Score is reviewed in about 10 minutes. There are online tools to get training and certification on it too. I hope this short overview will help you think through the general steps that should be considered when taking care of acute stroke patients. Please, review the disclaimer in the description. In the description, you will also find links to some of the relevant bibliography. Thank you very much.